even though we have made a lot of progress in the last 10, 15 years in improving overall survival in multiple myeloma patients, unfortunately, it's still incurable disease. So we're looking at it as a chronic cancer or chronic illness that needs chronic maintenance treatment after the induction phase of the treatment. That's a very good question. The reason we decided to do the US MM6 trial, which transitions injectable form of proteasome inhibitor with bortezomib to an oral agent with ixazomib, is most of the time in real world setting, the benefit that you see from prolonged PI-based treatment doesn't translate into the community. There are a lot of reasons for that. One is patient adherence issue because of different reasons. They might live far away from the cancer center. It's quality of life issue too. They don't want to get injection as compared to taking oral medication. Financial reasons, and also side effects from the medications, including neuropathy from bortezomib long term, is a real problem. If we transition this patient to a less toxic medication and easy to take medication, we think patient will stay longer on therapy. When they stay longer on therapy, they will get all the benefit they will get from PI-based treatment. Well, in our study is preliminary, is still ongoing right now, but what we decided to make the transition is after 3 cycles. The way we did the MM6 trial is patient who are transplant eligible, they will get bortezomib-based treatment. It could be a triplet treatment, or it could be a doublet treatment, and after they have achieved stable disease or better, after 3 cycles of treatment, we decided to switch them to ixazomib-based treatment. The reason we did that is most of the neuropathy you start seeing on the bortezomib-based treatment around the 3rd or 4th cycle. And the other thing is we want to capture the patient that might start on therapy while in the hospital. So based on our study, we chose after 3 cycles. Ixazomib in combination with Revlimid Dex is already approved for treating recurrent multiple myeloma patient. In a randomized phase 3 trial, it has been shown to be better than Revlimid Dex in recurrent multiple myeloma patient, and it has shown to be safe and effective in that setting. So we're just taking that regimen into frontline setting. It's good that we have a lot of active triple and double regimens that are available to use in treating newly diagnosed multiple myeloma patients. There are a lot of factors that we take into consideration: what to use first, when to use it, and this includes how the patient performance status, whether they're a candidate for transplant or not, the risk, whether they're high risk or low risk based on their cytogenetic abnormalities in the myeloma cells. You take all this into consideration and decide what kind of regimen you use. And if they are transplant ineligible candidate, and the goal is to keep them on some sort of treatment. Even after the induction phase, you keep them on a maintenance treatment for a long time until progression. So it's better to have a less toxic medication and more convenient to take if they're going to be on it for many years. So our data, hopefully, if it holds up in the future, it will be one of the options to keep them on long-term therapy.